Nā mai, haere mai, kia ora, tēnā koutou katoa. Welcome everybody to Back to Basics, hosted by the New Zealand Telehealth Leadership Group. And it's great to be kicking off this the year with our wonderful panelists here, and I'm going to let them introduce themselves in just a moment. So the idea of this webinar is that it is a Back to Basics, and we're going to launch in with a discussion shortly. But what I'd like to do first is share my screen briefly, because I want to show you good folk what the New Zealand Telehealth Leadership Group have been working on just towards the end of last year as a brief introduction to us. And you'll find this slide on our website, www.telehealth.org.nz, and you'll see here that we've got a vision statement, which is that telehealth is embedded across the health sector as an equitable and sustainable way to deliver healthcare in New Zealand. But what you'll also see, I hope, is you'll see a circle diagram there, which has got I guess our milieu, if you like, which includes our wider New Zealand Telehealth Forum, and then the New Zealand Telehealth Leadership Group, and our executive and our working group chairs. Now, this group's growing all the time, and we really do welcome new members. So do pop onto our website. We don't have a membership fee. We just want to be inclusive. And we've also just recently launched a research collection, which is basically a grey literature. We're not after peer-reviewed journals. What we're after is just what you guys are doing out there. So go ahead and have a look and see what we're doing up there. And I'm going to stop sharing. And I'm going to move on and reminding you all to use that Q&A. And I am going to start on, oh goodness, to my right or to my left, so much choice. I'm going to start with Andrew. Andrew, can you introduce yourself, please?
Yeah, sure, absolutely, Ruth. So my name's Andrew, and I work behind this telehealth.org.nz website. So I'm one of the team there that run that. I'm part of the New Zealand Telehealth Leadership Group. So a couple of plugs from me, telehealth.org.nz. Do go and have a look at the website. And I think just a word of warning, our website did suffer a little bit over COVID as we just chucked everything at it. So over the next few months, we're going to go through and you'll see some updates and changes. And I'm also the one behind the email address help@telehealth.org.nz. So if you email, I'll get the hard questions, so try your best. Send some tricky questions my way.
Yep, the harder the better, obviously. And just before I move on to Yari, can you tell me what you wish you had known about telehealth pre-COVID?
Me? Okay, pre-COVID.
You, yeah.
Well,
yeah.
I suppose what
you wish you'd known before we went in?
Well, that's an impossible question reflecting back, isn't it? I think that probably what I learned is that when we're really pressed, we can move really fast. So I think until we're really pushed into a corner, we kind of we don't really move, or we're not as agile as perhaps we should be. And a good example of that is the prescribing legislation, for example. So that was a big a challenge with telehealth, and we quickly saw that kind of fade away or fall away through some really, really good work. So I think what I learned is let's try hard, let's move faster.
Excellent, thanks, Andrew. And shoot your technology questions to Andrew. There's very little he doesn't know, so shoot those away. Yari, let's come to you, my friend.
Thank you. Thank you for having me. So my name is Yari Dorn. I'm a child psychiatrist by trade from the Taranaki DHB, and I have the pleasure of being the deputy of Ruth on the leadership group in telehealth. I'm also a liaison for the IT department in our DHB in Sun Midland. And a big advocate of telehealth. Obviously, I had some experience in some studies in Boston, and trying to implement that ever since with various degrees of success. But yeah, that's me.
Thanks, Yari. And for you, a lesson learned or what you wished you'd known before COVID?
Well, with the risk of sounding boastful, I wish we've known that we were right all the way. You know. I find, that we're dealing with a lot of people in the IT or health IT, and I think one of the common things that we share that we all have great ideas. And if you've been out there and tried to promote a good idea, you'll know that you're going to have some successes and some failures, which is part of the process. But there was something about telehealth, at least in my region, that I felt like I'm fighting against the current, and it actually made me doubt myself at some point, saying maybe I'm bringing models from different countries that maybe are not that powerful in New Zealand and that useful, or the culture is that different. And then when COVID hit, I had a moment where I was like, okay, that was a good idea. Now let's just make it happen. And Andrew, I agree with you completely. I agree. There was a sense of, yes, we can move forward and faster. And I think as a psychiatrist, I can say that sometimes we just talk too much and we just need to do a bit more and be a bit braver. Definitely agree with you, Andrew, on that. That's me. Thank you.
Excellent. Thank you, Yaro. Right, and we're going to go to the good Dr. Curtis Walker now. Curtis.
See, when you said good doctor, could have been any one of whoever many hundreds of people are watching this right now. So I was, who knows the lead in. Kia ora Ruth, and kia ora koutou mā. Nā minhi nui ki ngā kaimahi kua tai mai nei mō tātou nei hui. Tēnā koutou. I will just start by saying, see, telehealth is sort of one of these awesome technologies that means that we can deliver healthcare effectively, safely when done well, in settings that it would otherwise either be difficult or impossible. Now, where I'm this is a little photograph of Whananaki up Northland, and if you look off to my which shoulder, that shoulder there, that's my right shoulder, your left shoulder, about there was where Winston Peters was taking the photo fishing during the major COVID lockdown. Unfortunately, I'm not actually up there this evening, but this is another miracle of modern technology, like telehealth. Medical counsel, and so ko wai aho. I'm Curtis, I'm a nephrologist at the Mid-Central DHB, and I have the privilege of being the chair of the Medical Council. and we had our role to do in terms of reviewing our telehealth statement pretty quickly, as Andrew sort of says, and trying to be agile and right touch and all of these sorts of things, while essentially trying to make sure that, what doctors were wanting to do, having to do, and in some cases resisting, the new models. So we're trying to be both permissive and ensuring that the important considerations around the safety of telehealth in this brave new world were being maintained. I'll just summarise my upfront thing by saying Medical Council is a strong supporter of telehealth as a safe and effective means of delivering healthcare where it may otherwise be difficult or impossible, while recognising some of the potential risks that doctors and patients may face when engaging in this form of healthcare, of which you'll be very familiar and of which we're going to touch base on today. So no, strong supporter, and done well, done right, done safely. It's a good thing, and that's what we're all here to hear a bit more about today. And not only was it essential last year, but it's going to be essential and important in the years ahead, and growing, and so it should.
Yeah, thank you so much, Curtis. And it has really been fantastic to have the council so proactive and supportive. Tell me just one lesson learned, or what you wish you'd known pre-COVID.
I wish that we'd known that all of our statements weren't quite fit for modern purpose, as it turned out, and as the rubber met the road. But what I learned, I guess, very similar to Andrew and everybody else, is that when we have a can-do attitude, we did do. And the main lesson I take is that we need to hold on to that mode of being able to do things and not fall back into the old way, not only of practicing, but also of how we make decisions and come to the how we make decisions and come to the right conclusions.
Excellent, thank you. And I see we've got some more folk have joined us, so welcome. It's lovely to have you on board. Please use the Q&A to put some questions in, otherwise you will have my questions, of which I have many, and as you know, it's very difficult to shut me up. So put your own questions in, otherwise you'll be left with mine. Sam, please introduce yourself.
Good day, everyone. I'm Sam Merton. I'm the president of the College of GPs. And I must admit, I agree with everyone else that we were really nimble at the time, that we needed to be nimble, which was amazing and awesome for patients' sake. And having the backfill of support from the prescribing staff and the telehealth recommendations from the council and working all together was a really good thing. I think if I thought about what I wish I'd known, I think sometimes we think that we're not up with the play or ahead of the game or doing a good job in New Zealand compared to the rest of the globe. And while I was on, during lockdown, I was on 2 different telehealth webinar processes through Australia and also in Scotland. And we are totally up with what everyone else is doing. And I think the thing that I'd like to see is that sort of lead from the centre, which the telehealth leadership group is really helpful for, but that, you know, that ability from the centre to say, look, this needs to be driven, and then it being driven through. So that's what I learned, is that we're actually good at what we're doing, and we jumped in boots and all. And I just like everyone to continue to do it, and that's the hard thing, is carrying it on. Yeah.
Yeah, I think the sustainability part and moving to business as usual is the challenge from here, and I guess we can discuss that a little bit now. And certainly, I think the collaborations that we've built up have been important. And for those who've also just joined us, please be aware that you know, you can join the New Zealand Telehealth Forum. We have regular letters, and we welcome you know, new members. It's entirely free, and we'd love to have people on board. We've got our first question there from Steve McLean. I hope I've pronounced that rightly. I'm sorry, Steve, which is a great question, and I think it's something lots of people have struggled with. So it's talking about having some video consultations during COVID level 4 lockdown. It didn't work so well. I used DoxyMe, which is a common platform that many have been using. And then talks a little bit about struggles with setup and chewing through phone battery really fast and poor quality of images, and then settling really for telephone augmented by email. So what I'm going to do first is I'm going to ask Andrew just to comment on the tech, and then I'm going to move to Sam and just ask her to comment a little bit about the struggles and challenges, particularly in primary care, and how we may be able to help overcome those from that perspective. Although I'm assuming this is a primary care question, but there'll be others using DoxyMe. Right, Andrew,
Okay, well, yeah, I'll avoid the tech a little bit, but I'll come back to that. One observation we did have is during COVID especially, there was a few groups of people, and one group was those that had already dipped their toe into the telehealth bucket, and they already had a camera, and they might not be doing a lot, but they had been doing some telehealth, and we saw that those people were able to accelerate and rapidly kind of scale up what they were able to offer. The challenges they had was things like booking and integrating the system as their workflow as the volume increased, and the other group of people that they hadn't dipped their toe in at all. So that was a bit like this question here, whereas they were trying to find a camera, trying to find a computer, trying to get all the basics working really. So a lot of people did struggle, and there's a lot of little technical things that you just need to try and work on, and you'll slowly pick off one by one. You'll pick off how to use the cameras and what software platform to use. All those things take experience. So specific to that one, DoxyMe, for example, has different pricing tiers, and the more premium pricing tiers, you'll get a better video experience. The better your technology is, the more modern the computer is, the better processing it's got, so the better video quality you'll get as well. But I think the key is that we need to take that lesson that perhaps we're on the back foot, and we need to not wait for the next crisis to prompt us to keep going forward, but to start to try and do some video consultations when the heat isn't on as much now, so we can experiment a bit and we can slowly get better. So without answering that, we can answer those technical questions. I'll email that person back, but in general, I think we just all need to gradually learn.
Yeah, thanks, Andrew. And we are all in it together, which is a definite bonus. Sam, do you have anything to add there? Because I know this was a common struggle in primary care.
Yeah, I think generally across the board, we found that the struggles that I personally had, and I think others did as well, is, you know, being video centric as commonly as you can is quite difficult in a GP setting, because our whole appointment systems are quite different. If you're doing video or phone, how's your billing system going to work, and making sure that that works really well. We found that if you texted someone, they could be anywhere. They might be sort of at work or in the loo or whatever when they received the text, which doesn't really help them to be able to pay immediately. So we found that actually emailing was a much better way to do things. So it's actually just learning all the little bits that make the whole system work easily, and which are the hurdles that you have to jump and what the solutions are. I think from a general practice point of view, we have to grasp this nettle, although it's hard and tricky and very difficult at times, and there are lots of hurdles that we have to jump. Others are going to take over if we don't do it ourselves. And for an accessibility point of view, it is way better for patients for various things. I had an example the other day where someone rang in and said, I've got this thing on my leg and it needs to be looked at today, and I'm half an hour away, and our appointments didn't work, but I had 15 minutes right at that minute to be able to, and I said, well, if you can video now, we'll do a video now. So she got her consultation on the day at the moment that it was needed, and which was great access for her. She could then go off and pick up the kids and do all the things that she wanted to do. So I think that nimbleness that we showed when we were at the beginning of this and we're going like, okay, we're going to switch overnight. I think we need to keep that nimbleness in our hearts and minds as we do our day-to-day job. And that doesn't mean that it's hectic and chaotic. I think it just means that actually you could just throw that process in if you needed to, or and then over time, as it becomes easier, then it just becomes a norm and people will get to accept it. I think the biggest thing that we've had to deal with this year and will continue to deal with is actually transforming what the public want and how they feel about it. And I think for them, it's quite tricky, and that's okay. They love to come in and shake our hands and see us in person. But I think sometimes we need to be able to be flexible. So keeping up that flexibility individually in every practice is a really important thing.
Excellent, thanks very much, Sam. And yeah, there's more information that Andrew will obviously send out. I hope that answered a bit of your question, Steve. I can see that Nigel Miller's joined us. I'm assuming, Nigel, that you're joining us from the South Island, and if you are, I'm planning on coming to visit you, so please email me because I want to stop by. But Nigel's got a great question, and I'm going to throw this actually at Yariv and Curtis. How can we take giant steps like people on the moon in an emergency, but later we've lead in our boots? What causes this bit of inertia that we started off with? Yariv, I know you have an opinion on this.
So again, I'm wearing my psychiatrist hat every time I can, and I apologize for that. But I think human nature is to be habitual, and we are really stuck on patterns. I mean, just think of the last time you tried to get rid of a habit, be it a bad habit or a good habit. It's almost impossible. And I think once COVID has resigned, I think a lot of people had a bit of fatigue of telehealth, and there's an eagerness to go back to normal life. And unfortunately, normal life didn't include technology. So people just happy to go back to their quite bad habits and not use telehealth. And I find it mesmerizing sitting in meetings, even within my own team, and embarking pieces of data saying, look how many people we saw during COVID. I mean, I can tell you that my own team who went 100% telehealth during COVID, we increased our capacity and contacts by 140%. And we met the demand of mental health for Whanau and Tamariki without any doubt. We didn't have any suicide. We had the least amount of admissions. We were available as we ever were. And lo and behold, 6 months after, and my team is really split-minded about the telehealth. So I think I'll approach that in my own cosmos as a true psychiatrist, and keep on persevere and say, and be the active one who keeps on nagging people saying, we could do that in telehealth, we can do that. I think I probably speak for most of us saying that we all have clinics who might be in outreach in the rural places, and we still asking people to come and drive an hour or drive an hour and a half to see us, or vice versa. So I'm very adamant that these are the pockets where I'm trying to help and do more telehealth. It doesn't, you do encounter a bit more of the inequities. So while we're trying to have the right framework, whether it's Zoom or whatever landline, we do see the families who don't have that and don't match that. And I'm starting to build a list for myself of when to use telehealth, but also when not to. And I think this is where the inequities in your face, I'm trying to avoid telehealth because I don't want to rub it in. I don't want to re-emphasize the inequity, and I'll go the extra mile and literally drive. But yeah, I think the bottom line is just to be persistent, and I think eventually we will go there. I just want to remind I don't have a slide for that, but there's a thing, if you want to Google that, it's called the hype curve. It's quite a known curve in a lot of business endeavor where a hype happens and you can see that the motivation to use whatever you're offering, be it a new computer, a new AHR, a new car that you just bought, the first few days you're in a hype, and then this hype crashes because once the hype is not there anymore, people are bored and want to move on and actually keeping away from that. And then there's a very slow curve that takes you back to, let's reuse that invention that we used. So it's called the hype curve. Have a look at that. I think it's applicable for everything, including relationship between yourself and your brand new partner or whatever. There's always a hype. And after that, that's like, whoop, we need a couple therapy. And then, oh yeah, we've been married for 25 years, actually works. So yeah, Google that up. You won't be, you'll enjoy that. I'll stop here because I can talk for 2 hours.
Excellent. Now we've had telehealth related to marriage. It's always a good webinar when that happens. Thanks, Yo. Hey, look, I'm going to go to Curtis, but just before I do that, I can see that Foston has joined us. He's not bombing us, although he has threatened to hack us before. He is our cybersecurity expert, and I'll get him to introduce himself after we've talked to Curtis. So shoot him some of your really tough cybersecurity questions, please, because he loves them. Curtis, your comments on lead boots post moon landing.
Yeah, I was looking at that, and thank you, Nigel. And I am assuming it is the Nigel from down south. There may well be other Nigel Millers, but that's the sort of question that the Nigel Miller I know from down south would have asked, and therefore probably has. Well, the fact is with the moon, the hype train, we went there how often? And between 1969 and 74, someone who's older than me will know. And we haven't gone back there because of the hype train, the lead boots. We know in medicine, I really love that you're bringing that up, Yara, that the hype train happens commonly in medicine with a new drug, a new procedure, a new what have you, and then it disappears and becomes mundane. So the challenge here is to really thoroughly integrate telehealth and as an essential standard within each of our practicing environments. And if I reflect on how we did, yes, we were forced to do telephone consultations through the height of lockdown. But once we could come out of that, I had and still have colleagues who are saying, well, but you can't do this. You can't do physical examination. I can't, assess their fluid balance. I can't get a blood pressure. We know that with some thought and energy and ingenuity and possibly having remote site physical access and careful selection of patients, that's either not necessary, and that is a practitioner judgment thing, or it's something that can be overcome to still facilitate the telehealth. So there's a lot of these people initially jump on the train and then all the initial but what ifs and barriers and that start coming to the fore. And I think that also has a role in slowing down the hype. Sam, I just want to pick up one thing that you mentioned about what if you phone the patient and they're on the toilet. Now, obviously there's a specific situations like that, but in general, I just want to remind people that it is still a standard and expectation that you get consent for people for telehealth. Do you mind if I give a telehealth consult while you're on the toilet? I don't know, probably don't want to go that far, but just in general, a telehealth consultation, it's a consent process. And I do this when I've, had telehealth with patients. Look, I acknowledge this is a telehealth consult that we're doing it this way. But look, if you're not comfortable with this, then we can look to convert to another appointment as soon as. And that goes on with our booking processes, and so that patients are upfront done that. But it's always nice to check that when you're first in the room. And I really like you again, Yara, of the discussion around equity and how do we make sure that this tool improves equity, which is to address the big inequities that are out there. So how are we using this tool to improve equity rather than potentially, and again, if somebody's got a camera and they're pushy, and I'm going to do a video right now, it's beautiful, it's access, but does that increase the healthcare disparities for people who don't have those technologies? And I know that it improves people, for me, who can't come from Levin to Palmerston North, but yeah, just a couple of things. So the consent, the equity, I fully agree with Nigel's things about the moon landing because that's happened with the moon landing. And how do we overcome lead boots? I think actually colleges and societies should actually say to practitioners, here's the circumstances where we really expect you to have a telehealth. There's a big, bold idea. If my nephrology society said, here's the circumstances you can do this, and it's comfortable to not do the blood pressure or whatever, run your clinics like this. And service managers to also say, what's your telehealth plan to departments and clinicians? PHO managers, I presume, could do the same. So, you know, our colleges, our professional societies, our employees can drive it even as we want to do it.
Excellent, thanks, Curtis. And I think if we've got a bit of time, it would be good to go back to that consent part, because I know that does bother some people, you know, specifically in terms of consent for a telehealth appointment. And I would just say to people, there's a really, there's some great patient information which has been provided through Health Navigator. So for those people who don't use Health Navigator, there's a really awesome patient information regarding telehealth, and I think that's quite useful as well before a telehealth appointment. And you can also get that information through our telehealth website. Falston, would you like to introduce yourself, please, and tell us one lesson learned or one thing that you wish you'd known pre-COVID?
Yeah, sure. Thanks, Ruth, and apologies for being late. I wasn't intending to do any Zoom bombing or anything like that. I had some logistical issues. So I'm the Chief Information Officer for Patients First. That's a part-time position. I'm also involved with the New Zealand Telehealth Group for some time now, I guess 3-4 years. In particular, my focus is on cybersecurity. And I'm also the Director of Medical IT Advisors, where we do cybersecurity operations and digital transformations with a bunch of healthcare organizations that we support. I'm originally from Romania. My background is in IT, healthcare, and nuclear physics. I've built a couple of hospitals, and I've been in a couple of roles to share medical data across Europe. And I'm, I guess, 6 years now in New Zealand, and really trying to use my expertise to, I guess, help the healthcare systems do better. The biggest lesson that I learned last year, I guess maybe not a lesson, but the confirmation of what we know already. I learned that the technology is not an issue when it comes to telehealth. There are a few quirks and a few issues there, but I believe the biggest lesson in terms of adoption are people and processes. Basically, where there is a will, there is a way. I remember, you know, when we were discussing for a couple of years in terms of adoption of telehealth, and then over a weekend, we had to prepare for a massive adoption in primary healthcare for this technology. And I really believe that, you know, embracing remote consultations overnight, it's doable, has many pros, has a few issues, a few quirks that certainly can be overcome in terms of technology or maybe bandwidth and even access to I guess data, for example. And there are some few successful initiatives and projects here in New Zealand. Not sure, by the way, if those were mentioned today, but they were awesome and possibly even first across the world. And definitely in terms of telehealth, I believe it's definitely here to stay. So the lesson again was that really technology as it is not the issue. I think we need to work a little bit more in terms of people and processes. I guess all of us learn a new word like Zoom bombing, and I guess, you know, the all-time favorite phrase, "You're on mute." And now I would say maybe leaning towards my area more seriously, we learned that not all applications are as secure as they claim to be. For example, Zoom, where we are right now, I think we learned a little bit about their level of encryption, and then, for example, protecting meetings with a password, and then how those suppliers quickly overcome those gaps in security. But I guess it was a little bit of learning curve for the users that maybe believe that, you know, it's a secure product. So I guess that's a lesson that we need to learn and we need to adapt. And that obviously, I would say as a general comment, security threats are there to stay. And the more you are using something, the more it's more appealing for the bad guys to get in. But that should not be a barrier. And in fact, again, I think telehealth has proved to be easy to be adopted from, or let's, maybe stick to Zoom. Zoom was used in all sorts of contexts, from health to education to whatnot. So definitely there's a big potential there. And maybe again, like what Curtis was saying, we need to adapt to this new world, but at the same time understand the risks around it, and invest maybe a little bit more in training, in education, access to this technology. So obviously to access Zoom, which is a software platform, you would need to have the right capability, internet and all of that. So I'll stop there in terms of lessons learned, and I think we are constantly learning. Last year or this year, that doesn't matter. I think that's how it should be. We should learn and adapt and make it constantly better.
Sorry, can I just Zoom bomb and say,
thanks very
Nigel
much, Foster. And if
Miller's,
anybody wants to,
so I was just going to Zoom bomb and say Nigel Miller's on fire with these good ideas that he's throwing up there in addition to questions. I just wanted one thing. Training is essential. I really like the idea of more training from the day you enter medical school to the day you exit medical school and come into pre-vocational through our colleges. Training in this so that the next generation of doctors are telehealth natives surely has to be a goal.
I totally agree with you, Curtis. And, I think digital literacy amongst the health professionals is really poor. And that probably leads into the question that Ray's actually got here as well. And it's frightening. It's really scary for people, because we don't understand the technology, we don't understand the security aspects, and we don't teach it. I would say that the New Zealand Telehealth Leadership Group are working on developing a competency framework. And that won't be a new thing for Sam. We've had conversations with her and the medical council about this. So hopefully that will be in the first part of this year. It takes a little while to develop, and I think that idea of simulation is awesome, and great chat. Yeah, I'm enjoying it. So what I was just going to go to Ray's question now, and maybe before I do that, if anybody wants to be really, really scared and they use LinkedIn, then follow Foster, because you'll be kept up to date with the latest cybersecurity threats and be very worried. So look, Ray's put this question up and about winning the hearts and minds of, and he's actually said consultants first / providers, but in my experience tripping around the country, our senior medical officers seem to be probably the biggest barrier in terms of the district health board and jumping onto telehealth. So I'm going to go around our team. I'm just going to ask them just to spend a few minutes just trying to answer that question about how we can help our colleagues, I guess, come on board the journey.
It's a really tricky one, isn't it? It's a change management situation. There are no easy answers. I think that we just all need to lead by example. Promote cases that we know work well, and through that hopefully people will catch on, and when they get the opportunity to try telehealth they'll enjoy it and do more and more and more. I'd send them to Yarif. I'd just get Yarif to probably call them.
I don't know if easy, but I agree with you that demonstration is important, but I want to say something blunt. I think if you look at doctors, for example, as a part of the medical association or whatever, doctors are a bit of a, I don't know how to say it gently, we are a bit of princesses, aren't we? I mean, I'm a doctor myself, so I can mock me, okay? We are a bit precious, and we are all very busy, and when someone else is doing something, we look at that, and our defenses would be to say, oh, I don't have time for that. So what I've done in our hospital was to make time and sit with my colleagues, just to be there with them and just make them do that almost. So I sat with the gynecologist and I sat with the orthopedic surgeon, who said, there's nothing for telehealth for me because I need to touch my client. I would like to quote something from Boston. I was there in a wee bit of a course in Harvard, and they put an Alexa device on desks of doctors with consent, obviously, from clients, and they measured how much of the content that was captured by Alexa was actually relevant to the clinical questions at hand. And the answer was about 17%. So the rest of the 83% were about how are you, how's your wife, how's your dog, the last football game, whatever. But it was 17% about, so, you know, I gave you, how's your pee? You know, we gave you something for your diabetes. Did you pee more? Did you pee less? Whatever. So when they looked at that, they said, actually, we can do telehealth in every profession, because what you need is the essence of it. So when I said with the orthopedic surgeon, I showed him how most of his conversation was about the pain, was about the movement, was about whatever, well-being. And I would say 8 out of 10, touching the client wasn't an issue. So I spent many hours, to be honest, with a lot of my colleagues, and just not allowing them to be precious. So my takeaway message from that would be that I think if a DHB is really serious about telehealth, the DHB needs to allocate someone for a 0.5 and say, let's make it a project for the next 6 months. I think there's another layer that's really important, is it is to streamline the whole admin behind it. It's a bit of a pain to start sending links to everyone. My admin, for some reason, can't do that. If we could just streamline, you know, the webpass, the Outlook, the whatever, that would be great. In my little garden, what we've done was made it mandatory almost to capture emails now as part of the very basic demographics. So when the moment comes and we need to use whatever invitation, we have the data that we need. So it's the nitty-gritty stuff, lots of hours. So no easy process here, I think. Yeah.
Excellent, thanks, Jerry. And certainly I've heard a number of people who've done this successfully say it takes a silver spoon approach, and you know, SMO to SMO, or you know, nurse to nurse, and I think that Lynn Clark commented that also. Curtis, what would you add to that? What are your?
Oh, I'd endorse that. I mean, it sort of reinforces what I was saying about if the experts in the subject matter fields and the vocational fields, such as colleges, can provide sort of the vocation-specific guidance for, say, for example, orthopedics, and sort of say, look, under these circumstances, it is perfectly fine and acceptable within our scope of medicine to be offering telehealth consultations. Psychiatry, here's when you should. Here's some areas that, you know, you've got to be cautious about. And every specialty is going to have some of those. Of course, general practice is going to have every single one of those all wrapped into one plus more. The joyful, difficult nature of general practice. But I think that the colleges do have a role in supporting clinicians to feel safe and secure to do it, alongside the individual champions in DHBs. Yeah, and look, by the time you've got DHBs, and I know I sort of said DHBs and PHOs saying, bring us your telehealth plan clinicians, and we have, you know, I've had some colleagues say, look, my department's putting pressure on me to do this. Can I just say no as my rights as a medical practitioner? And that all gets a bit messy. That would be more of a wooden spoon approach, but I would prefer the silver spoon approach, which can be led significantly through colleges to allow champions on the ground to unroll it. I don't know if anyone from the colleges is on. I know, Sam, you are, but, you know, other colleges, for example, as well.
Yeah.
Physicians.
And certainly from an emergency physician, you know, as myself, we've actually formed a telehealth effectively interest group, which is lobbying for just those things, and basically writing those things for our college. So if there are members out there, I know Yariv, you know, the College of Psychiatrists has done something similar as well, but lots of lobbying. It does make a difference.
It's a really interesting question about all consultants, even in general practice, about, you know, how often do you write down the examination findings are? Because, I mean, I think we don't want to just be the neighbour as a consultant and just have a chat, but we do know that history is the most important thing for when we take looking into a medical condition that a patient has. And so if the majority of that history can be done over the phone or whatever, then absolutely we should be. Patients, if we think patient-centric, patients shouldn't be driving for an hour to go to a hospital to wait for 3 hours to see a consultant who they could have done that conversation over the phone. And that's not fair on patients. And I think we need to be able to think about it in a patient-centric way, that actually if we're resisting this, why are we resisting it? Is it about safety? I don't know that it absolutely is, because there are lots of ways that we can encourage people to be safe. I think we need to be really drumming home to our clinician colleagues that actually this is about best care for patients, and that inconvenience for patients in a way that is actually really safe. And so making sure that we've got all the checks and balances around so that we can do it well, and that we can agree to saying to a patient, you have to come in because I need to examine you, is an absolute. But we should be able to say to a patient, I can do this over the phone, so you don't have to turn up at the office and wait for an hour, or drive, or pay for parking, or whatever it is that needs to happen. It used to drive me nuts that I would work in minor surgery. I'd drive all the way to the hospital, and my patients would drive all the way to the hospital, and we'd all have driven for half an hour, which is a greenhouse gas expense, and then I would operate on them, and then we'd all drive back again. And you just go, this is just nuts. And so I think, we shouldn't be doing that with any service that we deliver. If we can possibly stop travel that is unnecessary, and it's only the unnecessary travel, then imagine the impact we'd have.
And certainly from DHB perspective, the requirement now to be more responsible for your emissions, as well as the cost savings of travel, is stuff that gets included now in business cases, which is definitely useful to consider. I can see that Faustin is furiously typing an answer to Catherine there. Faustin, did you want to just very quickly address that before we move on to probably one or two more other questions?
Yeah, sure. And I panicked a little bit since I've answered it, and then it moved from open to answer. So I'm trying to find it again. So the question was the video recording of the telehealth consult shared with the client fully for the purpose of managing transparency versus preservation of privacy. I think it's a really good question. Certainly something that would happen with or without consent, but I do believe it's a matter of consent. I think Curtis was mentioning before. You do need to before you start these interactions, these engagements. I think both parties, in particular patients, need to be aware of what was the right context. And asking for their consent, and in particular, just not just the writing that everybody gets, and like accept the rules and the tick boxes that everybody nowadays is used with any apps. It's like yes, yeah, whatever. I don't understand, but yeah, okay, whatever. Let me just get on with it. I really believe that. Patients and also users, not patients, I would say just generically, patients of this technology, users of this technology, whatever they might be physicians, they might be patients, or might have different roles, even admins and maybe, looking forward into training, there might be some other parties involved in that consultation. They need to be aware of the risks, and everybody needs to be comfortable. And also, I believe there are different contexts, and you need to be sensitive of the background and I would say the bystanders. I think that New Zealand Telehealth already provided some of the guidance in terms of how, from a provider point of view, how you should set up your environment in order to have the best conditions for that. So again, maybe that's not always true. So if you are somehow not in that special environment that maybe you are in a restaurant and you get a call from a patient and you must answer it. Again, be sensitive of that. And also I would say be sensitive of anyone else that's around you, because that might impact the trust that both parties are putting in that interaction. So as always, just apply common sense, and you know, if you would not feel comfortable in normal conditions, then don't do it. So only, you know, use your common sense and your judgment to do it properly, and make sure that honestly patients understand that whatever is the conversation might have some private information in it. So they also need to, by the way, take ownership of that. So I would add to the whole consent, not just recording, but in general engaging with telehealth, making sure that patients understand that they have an obligation to protect that interaction. So in particular, their accounts, and you know, maybe we can consider also delegated authority to see some records, or on behalf of someone to engage. So just being aware of different circumstances, and definitely take care of their identities and accounts. That's you know, just on my side, again, banging on the cybersecurity drum, but identity is one of the biggest risks that we have, because everybody has an email now, you know, maybe Gmail or whatever you have, and that's being compromised. And through that, you can access all sorts of things from your telehealth account, or maybe your patient portal or whatnot. So just beyond just telehealth, be mindful of I guess some basic principles about your identity online, your privacy online. Try to learn a little bit more about that, and maybe take some meaningful steps to protect that, like multi-factor authentication. That's a good example. It's not that hard to use. Most of the services nowadays support it. And I would say, lastly, take care of or understand a little bit about phishing as well. I am expecting that the more of this technology will be used, we'll see more phishing. So, for example, invitations from your doctors, or I would say nowadays, probably the theme of this year will be an invitation to get vaccination, or something like that. You know, click here to register to some vaccination website. So just be aware of that. And that's on top of the usual hygiene that you need to take care when you engage in a telehealth or any online interaction, like computer updates and patches and antivirus and all of that. So I'm happy to kind of provide some guidance on that. But again, coming back to the consent, just be comfortable and use common sense. I hope that answers the question. And yeah, it's not that technical. I'm trying to be as non-technical as possible, but there's plenty of technical guidance out there that I'm happy to also provide.
You know, that's great. Thanks you, Foster. And I think it also speaks to the digital literacy, you know, and the need to upskill ourselves as well as our patients. I'm going to see whether Curtis has got a comment on that in a minute, but we're actually going to wrap up relatively. We've got another 9 minutes or so, and I'm just going to seed that question for the rest of our panelists before we go. There's a question there from David, which will be our last one. And that's about experience from overseas. And maybe our panel can just have a think about that one lesson that they've seen overseas that we could use here. And while they're thinking about that, Curtis, did you have a comment to follow on about that conversation about recording from Foster?
No, I don't see it as being particularly different from, you know, when you're asked to record if a patient asks for your permission to record a consultation in person. You know, in that sense, it is much the same. I fully appreciate the arguments around the security of that, and I thank you for highlighting those. I've just put one thing down here about, I mean, I really like the analogy about, you know, you clean your hands when you're doing an in-person consultation and examining a patient to make sure there's no viruses. And it's a really nice analogy to apply to telehealth, is digital cleanliness. I might use that analogy in future. So that's thank you for that. And yeah, thank you for just picking up the kōrero from David. That David Dunbar is Council's registrar. So I'm glad that he's asking that. And what it says is that I'm not quite sure about what's going on overseas and would be keen to hear from others. So me and David might be asking that question. Sorry, Ruth. And because I might not get back to me because I've had more than enough time anyway, I just one little plug for the Medical Council election for all of those listening. Voting is going to open on the 23rd. Now, I'm not going to plug myself, but there are 11 very good candidates who all should be considered carefully. So make sure you vote in the Medical Council election opening on the 23rd. It'll come to your email because that's the modern telehealth world. Okay, that's all.
And just Curtis, for your good self and David, anybody else who's interested, there is actually a festival of telehealth, an international festival of telehealth, which sadly is being hosted in some of those wee small hours in February, though it's the end of this month. And I think some of it's being recorded. I've already talked to an amazing surgeon in Boston who's got really interesting things to say. So do try to get along to some of that if you can. And I'm sure we'll have that on our website. All right, a quick spin through, and we do have other questions there, and they're fantastic questions, one about ACC and another about collecting emails, and we're going to have to address those offline, I'm sorry, but we will get to those via the website. Andrew, a lesson learned.
Oh, a lesson learned from me. Well, actually, I'll just get back to those questions. So we will have a recording of this webinar available on telehealth.org.nz/webinars, and we'll post the answers to all the questions there, because there are some good questions. I quite like the aged residential care one. What we might do is we might do a special telehealth newsletter about some things that are happening in aged residential care around the country. There are some good examples, although it's not as widespread as we'd like. And there's a few really interesting questions. So looking forward, for me, I just want to keep the foot on the accelerator. That's my wish for the future, that we lock in these gains, maintain the momentum, and we just keep going forward at pace.
Excellent. So you and I are not going to be out of a job anytime soon. Yari, lesson learnt from
for me, lesson learned, I guess, would be that I don't need to reinvent the wheel every time. I found that every time I picked up the phone and contacted a colleague from New Zealand, from overseas, I found a beautiful answer and a beautiful project that is running. I find sometimes that my role is to gather solutions that work instead of trying to make it work myself. So I would definitely say, go out, don't be shy, ask. People actually like to help. Yeah, that's my plan for this year, to gather instead of hunting. Yeah.
Yeah, and the wonderful thing about video too is that I was on a call this morning at 6 o'clock to a colleague in the States, talking about what they were doing over there. So absolutely, just reach out. It's really good advice. Sam, any real take homes from maybe the Ontario sort of experiences or any of those other?
Yeah, I think from the work that we did in Scotland and also just looking at what they're doing in Canada, the thing about it is that they've got the structural system, which is actually national. And although there has been a flurry of different digital solutions that have come through that are individually funded and supported by businesses or business owners, I think they're actually, the thing that I'd like us to learn is that actually a national platform or a national support for some sort of digital platform that all our patient users can access is what needs to happen. I think there is the technical issues of data for patients, using a decent video for patients, being able to pay easily through these systems so that the practices aren't sort of waiting and delayed and having to remind people to pay. I mean, there are some really simple and nuanced solutions that I think as a government we could put stuff into, and that would be a solution for people. It's not for the industry or the business, it's for the patients. I think those sort of platforms and those sort of like whole of sector, whole of health ideas and digital support are really important. And we've seen it with the prescribing. It's been amazing. And I don't think anyone would go back to not having a barcode on their prescription. And I mean, who would have known? But I think the biggest barrier at the time when it first started coming out was actually this was going to cost the sector, like the health professionals, money, and how do we make that work when we're sort of like upfront having to pay for it? Whereas now we've just gone, okay, it's fine, and maybe that cost has been charged onto a patient and at a minimal level. But I think that's where we need to sort of like have the background support from the government agencies to say, okay, we'll give this to you for free for 6 months until it's so normal you wouldn't go back the other way. And that's what we need. Yeah.
Yes. I think that's awesome, and that's certainly something we have been talking to the ministry about. So anybody else who wants to get out on the bandwagon, please join the New Zealand Telehealth Leadership Group and help us lobby for exactly as you put it, Sam. We're actually 1 minute shy, so Prod Foster isn't going to get to add his tuppence worth on overseas stuff, but. What I would say is, Jenny, yes, we will. That's a great idea to do something on dental, and Andrew's already answered that one. We'll get back to some of these other questions also. Our next webinar is a month away and is going to concentrate on allied health professionals and nursing. I seem to recall. Andrew's looking at me quizzically. I'm pretty sure it is. But do keep your ideas coming if you've enjoyed this one as well. But I'd really like to thank our panelists for taking an hour out of their evenings to join us tonight. Really appreciate the expertise and the support. Every time I try and twist their arms, they're always pretty twistable, and I really appreciate that immensely. There you go. See, Curtis is doing a demo. So look, with that in mind, I'm just going to let everybody say ka kite, and we'll see you next month. So you can all unmute yourselves and say ka kite, and then we'll be off.
Ka kite.
Thank you all. See you later.
Alrighty.
Thank you. Cheers.